Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hi, welcome to today's podcast. In this podcast, I interview my colleague at the Auckland Shoulder Clinic, Pradnya Gadkari, about some recent research she has done on strength and force appreciation in people with shoulder instability. So settle in and listen to our discussions on proprioception, force appreciation, and all things instability. Welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder rehab. Today, my guest is Pradnya Gadkari, and it gives me great pleasure to discuss some of the research she has been doing. Pradnya is a colleague of mine at the Auckland Shoulder Clinic and is a fantastic clinician. Pradnya, did you want to share with everybody your journey to here and having this podcast with me? Do you want to, and I know that you trained in India, and do you want to share how it's been an interesting journey so far, hasn't it? So
thanks for having me, Margie. Yes, I've been working with you for almost 8 years.
Yeah.
But yeah, I didn't start working in this area of shoulder particularly because when I graduated in India, my interest was neurophysiotherapy, and my initial sort of clinical work was in neurophysiotherapy. I just decided to do my master's there. I did my master's, and I worked in a sort of a hospital setup, mainly focusing on neurophysiotherapy. Then in around 2005, got married, went to US, and I thought, well, while I'm here, I should do some further studies. So I enrolled in a class in Columbia University in motor learning, motor control, because I was always fascinated by how the brain works and how it controls movement. And then somehow along the journey, I started working musculoskeletal from then on. And I got sort of more interested in it. And when I moved here in 2011 and I started the postgrad paper at AUT, that's how I met you.
Yes, all those years ago.
And of course, with your interest in shoulder, I was like, oh, that's a joint that I'm interested in because, it has so many different structures around it and whatnot. It's a little bit of clinical challenge, diagnosing what the problem could be. And yeah, since then, sort of slowly gravitated towards shoulder.
Yeah, and it's been a fantastic journey, and Pradnya and I have lots of stimulating conversations in the clinic, which is why I wanted to ask you to come on this podcast. Pradnya has recently completed some research, and I thought it would be interesting for us to hear more about this. Pradnya, can you explain the key aims of this study, how you did your research, and why you decided to undertake the project that you did?
Okay, so I guess with working in the clinic, and as you see, we see a lot of instability patients, and I find them very interesting in the sense that some of them are trickier to sort of rehabilitate along their journeys, and pre-op or post-op. And I'm looking at it, and you see some patients who continue to have instability even after surgery. And that got me thinking, well, we are doing lots of things here. We're doing strengthening. Is there something that we are missing out in that whole puzzle around what we call dynamic stability aspect of it? And I think when I started slowly looking into it and understanding what does it mean, dynamic stability, what are the different sort of components contributing to it. And I saw that proprioception as a part of it. And there's been some research done around joint position since, but there wasn't enough research around something we call force appreciation, which is a part of proprioception. So I thought, that's an area which has not been explored. So then I got in touch with Peter at AUT, who was my supervisor, and we said, oh, why don't we do this project around force appreciation, looking at it in a post-stabilization sort of population. And
can I just interrupt there, because I know, I mean, your knowledge around this area is so vast. Can you just share with people what you understand about what we call shoulder proprioception, and can you expand a little more on that? I think it's a really nice little segue for us. Tell us about shoulder proprioception.
So proprioception is a sort of a area or concept where it's a ability for us to perceive where we are in space or where our limbs are in space, and also the ability for us to perceive or modulate the forces that are applied or generated within the joint. So joint position sense and movement sense, which is kinesthesia, is what we say where our limbs are in position in space. But then we also have a sense of tension or a sense of effort. So there are two different things. Sense of tension or force appreciation is the ability to perceive or modulate the forces generated within the joint or applied, whereas sense of effort is a slightly different concept where, you know, when you lift a weight and you can sense whether it is heavier than another one, or you've done something and you said, oh, what was my effort like? So it's slightly different than sense of tension. But the whole concept of proprioception is fascinating because there are multiple, the pathway, which starts from the periphery, like receptors around the joint, which are situated in, you know, joint capsule, ligaments, tendons, muscles. They all sort of are giving that sense of information. And then, you know, through the tracks that they travel through to the brain, how the perception of it occurs, and then it goes to the sensory cortex and to the motor cortex, and, you know, then the signals come back. So it's a complex sort of a system. And I think it's all happening like we're not aware of it. Conscious awareness is not there, but it is happening all the time. And this is what is contributing to the movement control. And if we make mistakes in our movement, then there is automatic adjustments happen, because a control of the movement is also, it's pre-programmed, so the brain can retrieve that. And if there's a mismatch, then, you know, the brain can send corrective signals to it. So it's a very complex system that is happening. So I think force appreciation is a component of it. And when we think of force appreciation, the way in the research paradigm what was done is you have a person sort of to understand how it happens, or we can't tell that where the problem could be, because it's a complex pathway, but we can just get a sense of whether the pathway and the whole system is working. So for force appreciation, it's been done in knee, in ACL injury and post-ACL reconstruction sort of population. And the research, I mean, the protocol or the experimental setup requires that you use a very submaximal force, because of course, when you're asking people to exert maximal force, it will be hard because you're looking essentially at force control. So you exert a submaximal force, that is, they can control it, and then they maintain it at a sort of a steady level. So there are different ways they've done it. Some people have done it with eyes open, eyes closed, a little bit more isometric or dynamic. So different ways of looking at it. So in my study, I specifically wanted to see that whether the force appreciation chose a position. You know, you can choose in different positions. Some studies have looked at with the shoulder internal, external rotators at neutral, but I wanted to see where this is a position of 90-degree, sort of an abduction with 90-90, where we see most of our patients who have the anterior instability, they tend to dislocate, or they sense to feel and a little bit of apprehension. How is it like in this population when they were 6 to 12 months from surgery and they were clear to return to sports? What was their force appreciation like? Because in ACL research, they've shown that even at 8 to 12 months, some of them, they were deficits in their force appreciation in their, operated side versus the unoperated side. So that's how I thought, let's see how it looks in the shoulder population. And what essentially it did was they had the arms sort of stabilized in the 90-degree abduction, sort of that position. Initially, we measured the MVC force for internal external rotators. And then it was set at 35% of the maximum because it's a sub-maximal level force. And they had a certain cue. So they could see a line which was set at 35% of the MVC. And there was a visual stimulus. So again, it's because you're, kind of involving the whole system of the brain and the other areas, because the visual cortex also plays a role in control of movement. So they had a visual cue, and as soon as they could see that the visual cue came on, the instruction was to get to the line of 35% MVC and maintain it steady for about 20 seconds. And then they could let go. So they got some practice trials because it's a new novel task. And then we collected 3 as the main trials. So it was interesting to see. So when they are asked to maintain it steady is what we call force steadiness, which is, the control of it. But the mismatch between what they can reach is called the accuracy. So I measured the accuracy as well as steadiness.
And what did you find? What are the key findings from your work?
Research. So I think, along with it, I obviously looked at their perceived function, their, fear of movement, which is with Tampa scale of kinesiophobia, their shoulder confidence in return to sports, and all other measures. And I also did their physical performance test, because we do know, like, all these different aspects, they play a role in, when people are now returning back to sports. So to see whether there was a link there was a correlation between all these different aspects. And I had some interesting findings with force appreciation. So I found that with the force steadiness for external rotators, and internal rotators on the affected side was less than on the unaffected shoulder. But the difference was for external rotators was 0.9%. So it was significant. And for internal rotators was 0.3%. Again, significant result. But then we thought, with such minor differences, does it matter? Like, does it at this stage, from the way I have assessed, do we need to change anything in our clinical practice? So I don't think it was clinically relevant as such. But my other interesting finding from the study was, because I looked at isometric force, I found that there were significant deficits in their strength. So external rotators were about 23% deficit across compared to the other side, and internal rotators about 15% deficit. So there were some deficits, and they were on average about 8 months from surgery. So there was a bit of concern that, these people had gone back to sports and they were cleared for sports, but they had gone back with strength deficits.
Yeah, which is consistent, isn't it, with some of Adele Fanning's work, that she's also seen then these strength deficits in this population who are returning to sport and they've been cleared to return to sport, but still with quite significant strength deficits. But the force appreciation is significantly less, but only, while it's statistically significant, it's only a small margin, isn't it?
Margin,
And I guess that, do you think, because with my understanding, you know this research better than I, but my understanding of the joint position test matching, again, significant, but only 2 or 3 degrees, isn't it? It's very small.
Small, yeah. But again, I feel like, Margie, I guess it's a starting point, because I tested it in a position which was very isometric task. It could be different if they had to really do a dynamic task. But it was hard to put everything in that 1.5 hour testing session.
Exactly. It's already,
my plan was to do both dynamic as well as isometric, but it would have just made the whole testing session a bit longer. But maybe we don't know which is more realistic, where they have really the force fluctuates. And in knee research, they have done that dynamic task, and they could see some sort of, bigger differences in that.
Okay. And I know we've talked also about the differences that you found with the physical performance tests and the strength, haven't you? Do you want to share? Because you looked at correlations there, did you?
Yes. So with the physical performance test I used your SATS test because I thought it was relevant in the population in New Zealand, thinking that most of them play rugby. So which were originally, I guess when you did it, probably more consideration in relevant to people returning back to, that kind of sport. And I did not find any sort of significant correlation between the strength measures, isometric strength measures, and the performance test. But with the function, sort of even like looking at the WOSI, the row, they were similar to research reported in other studies, which was, they were hitting the same sort of scores around what people would be at 6 to 12 months from surgery. But I saw that SIRSI, which is the Shoulder Instability Return to Sports Index, the main score was around 70. And I guess the maximum would be 120. So they were not particularly high in that. So again, I guess you probably would have more sort of, it's hard to tell what's the cutoff because we don't know that.
Yes,
but
and
at
there's
least
various cutoffs, isn't there? But there, I mean, just doing some quick rough math, 70s over 120 is more than 50%, isn't it? And we know from some of those papers that some of the cutoff proposed is around 55%. And so you're probably sitting at about the cutoff level. That people
just about the cutoff, but not,
Yeah. What's interesting, isn't it? Because I know from some of those biomechanical studies I did with the line hop side hold rotations, I know that they load the posterior cuff infraspinatus a lot. I know that infraspinatus is working a great deal there, but isometrically, not in a way, and also to restrain posterior shear of the humeral head, but not in a way that is external rotation. And so what you're seeing, and I know that EMG is not the same as strength. So let's be clear that I'm not making that assumption, but I do wonder then we rehab a lot, don't we, with external rotators, and we do that with external rotation. But actually what we're seeing when we're loading the posterior cuff in that flex position in a closed kinetic chain point of view, that they don't necessarily perhaps correlate. Do you have what are your thoughts there?
Because I also feel that when you're measuring the isometric test and the performance test, probably you're using a different system of muscular, because with the line hops, it is more of a power endurance because they are all 1 minute tests. So it's a different physiological system that probably also has an impact on it. Because there were no side-to-side LSI wasn't even significantly different.
So interesting.
That could be the reason.
So that's, I've done another podcast with Tim All recently, and we also we talked about, the endurance of that, the power component, and really what you're saying in isometric peak torque, there's a lot more other components. Is that what I'm,
Yeah, that's what I feel. That's why there was no, I guess, correlation between
so many things to measure though, and one clinical, like, are you ready? Because so the patients that come in to see me, they were like, well, am I ready to go back to sport? And they want an answer. And there's so many different components of that is what we're learning.
And it becomes, I guess, then harder to decide that, and again, they play different sports, so which test to use, because is it relevant for that sport or not?
There's lots of things to consider, isn't there? Just to sum up then, Pradnya, do you think like the next steps from here, so based on your work, like from what I understand, the force appreciation, there's no real clinical relevance then, you don't think, in terms of the static work that you did? But maybe there's more work to be done in the dynamic space there, or?
Maybe more work to be done in the dynamic space, more work to be done because without vision or giving them, I guess, distracting where cues, I think it's called, like, where they're using their cognitive biases challenged. So that's more to control this type of task. You can set it up or challenge in different ways. So maybe there would be deficiencies really, because perhaps in my study, they were relying more on the vision because they could see it, and keep it steady. When it's cognitively challenging or distracting task or without vision dynamic. So could be different in their population.
Do you just want to share with clinicians then what you do to measure proprioception, or what your thoughts are around clinical practice in this space? Have you got any advice for clinicians?
Well, generally, like since I do a rough kind of an assessment with someone with joint position sense, in the sense that whether they can sort of see where the joint is or match it with the other arm in that sense. But I think like I don't necessarily measure force because it will be hard to measure. But I also feel that how we start clinically, we are some ways targeting it, in the sense that when we start giving them some exercises and you start with little load, we're not giving them a maximal load, but sub-maximal load. And they're holding it and they're keeping it steady. So we are probably using that system.
Doing that. Yeah.
And there is research around this force steadiness around in other areas, which they have shown that doing some people, like they've done tasks like pegboard, tasks, which are more functional tasks. So there is a carryover between doing tasks which are functional tasks and then the force steadiness. Because you are using the similar sort of system, it's a sub-maximal task. You're using the recruitment of motor units and everything. So I think we some ways are working towards it if we work our rehab along that path.
Yes. Yeah. Okay. Cool. Hey, well, thanks very much for your time, Pradnya. That's been really interesting and nice to sit and finally have time to actually chat about your project and the implications of that. So that's really cool. Thank you very much.
Thanks, Margie. Nice to chat.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.